Good afternoon, and welcome to today's webinar titled Navigating Remote Patient Monitoring, What Health Systems Need to Know Before They Buy. My name is Jeanette Wider, and I'm Managing Editor of Healthcare Innovation. Today's program is sponsored by Avia. Thank you to our sponsor and to our audience for giving us your time and attention today. Before we get started, we have a few housekeeping details. To submit a question, please use the Q&A box to the left of your video window at any time. You do not have to wait until the end of the program. For technical issues, please press F5 to refresh. And if that doesn't work, you can submit a question with your issue through the Q&A panel. Finally, join our webinar conversation on Twitter. You can tweet using the hashtag HILiveWebinar. At this time, I'd like to introduce Sarah Carroll, Senior Director of the Center for Care Transformation at Avia. So Carol, why don't we begin by you telling us about yourself, your title, your background, your role, anything you want us to know.
Thanks, Jeanette. And it's a pleasure to be with all of you today. I've been studying public health improvements for over 20 years and patient engagement solutions specifically for about 10 years. An example and one that's near and dear to my heart, I spent about 5 years building a sticky solution for pregnant and new parents at United Healthcare called Baby Blocks. And it really helped me appreciate the power of behavioral economics, the power of data to support the necessary patient engagement process. It unlocked the mystery of motherhood, at least part of it, and it really led to healthier outcomes. And for the business, it improved our quality metrics and reduced NICU admits. So that has really fueled my energy to continuously improve in this space. And for the past 4 years, I've been advising Avia Network members. Our members consist of over 57 health systems now on their best moves in supporting patients with chronic and complex needs. And I've been focusing the last 2.5 years really exclusively on remote monitoring because there's so much opportunity to unlock business and clinical value.
Great. So if it's okay with you, I'm just going to hop right into the questions here. So the first question I have for you is that you believe strongly that remote patient monitoring technologies are the future of healthcare. Can you please explain your reasoning behind this?
Yeah, definitely. Health systems that I talk to are more interested than ever in moving beyond the four walls of their clinics and hospitals. And they're really doing that for two reasons. The pandemic proved to us that smarter, more convenient care is possible. And the second reason is because the U.S. population is getting older and sicker. Within the next 10 years or so, there will be more older adults than kids. And of those older folks, 2 in 5 adults will have 3 or more chronic conditions. So what I've learned from my own personal experience watching my parents age and in the data is that really older adults want to avoid costly nursing homes. They'll need help living independently. The most advanced health systems, in my experience, have recognized these converging trends, and they're moving rapidly to differentiate themselves among their competitors and to differentiate themselves among the incoming disruptors that we've all heard about, whether it's Amazon, Walmart, CVS, and the like. And I firmly believe that remote monitoring is just one of those essential technology capabilities that support the triple aim. So, I've seen data to suggest that it improves the care experience through more convenient connections. It improves outcomes. The data collection and earlier intervention are obviously clear benefits, and it has demonstrated to reduce avoidable utilization and the associated costs. Plus, we can't ignore the fact that we're all in the midst of a significant workforce shortage, and there's increasing evidence that remote monitoring can support care team efficiency and satisfaction.
Great answer. So how do you define patient monitoring?
Yeah, well, we believe at Avia that a strong definition starts with a strong analysis of the underlying problems that health systems face. And in our research, we've identified 3 big problems. First, health systems want to improve patient engagement. They want to improve care plan comprehension and adherence. Secondly, they really need to increase provider efficiency. To describe, the workforce shortages that I shared a while ago. And then finally, they do need to reduce readmissions, prevent admissions, and ultimately improve patient health. Every health system I talk to is mission focused, mission first, but there are a number of other business levers that are looking to affect through remote monitoring. So given all that background around our analysis of the three problems, my definition is remote monitoring is the ability for patients to share biometric and other data from the convenience of their home and for care teams to identify issues, exacerbations, and intervene earlier.
Very well said. So my next question is, maybe you could give us some of the top use cases for remote monitoring.
Sure. Well, I've led roughly 15 to 20 individual projects with health systems over the last 18 to 24 months, and every single project has mentioned uncontrolled chronic conditions as a primary use case. But if you really dig deeper under that, you could ask yourself, well, which chronic conditions and what combination? What are those specific business levers? It really gets back to health systems have a capacity challenge. There are not enough beds to admit everyone that needs one, and too many admitted patients could be more effectively managed from the convenience of their home. And also, most consumers just don't want to go to the hospital if they can help it. So RPM can really deliver value in three main patient groups. First, it can avoid some moderate acuity admits. Secondly, at discharge, remote monitoring can improve the care transitions and ultimately reduce readmissions. And third, health systems are targeting high-risk patients who are part of value-based arrangements just to ensure that their care plans are clear, that patients have all the tools and information they need to prevent an additional flare-up, prevent a readmission, and get their chronic conditions better under control. And finally, I'll just say, in almost every engagement, again, going back to pregnancy and postpartum patients, we continue to see strong interest in supporting those populations. There continue to be grant dollars available to reduce maternal morbidity or mortality, and that's something that I think is going to continue for the next several years.
Okay, so this should be a pretty good follow-up question here. How can remote monitoring exacerbate or perhaps improve health disparities, which is, I know you're very passionate about that.
I am, Jeanette. We've talked about this before, right? It's an excellent follow-up question to my last comment about a focus on the maternity population. Many decisions that we make as digital transformation leaders have tremendous downstream impact on health equity. And unfortunately, some of us don't pay enough attention to those downstream impacts. So an example is really asking yourself during kind of strategic planning for the adoption of a digital solution like remote monitoring, who's eligible for the services? Do they have access to devices? Do they have internet access? Do they have a data plan to use the services? Do they have any language or health literacy barriers? The good news is the best solutions in the market, and I've recently had deep conversations with three of the best in the market, they've overcome these barriers by identifying technology workarounds like use of reliable cellular networks, easy device provisioning and pickup, including writing messages at the fourth grade reading level or less, and including their solution in multiple languages. So I think these simple user interfaces are really leading to strong enrollment and strong engagement rates across the population, regardless of income, eligibility, capacity. And that's leading to stronger impacts as more controlled conditions reduce readmissions and emergency visits.
Great. Well said. It's such an important topic right now. It seems to be top of mind, especially in healthcare innovation, we're writing about how to improve health equity almost every day.
Wow,
So
that's awesome.
So I'm going to switch gears a little bit. So why have most health systems in the Avia network turned to a third-party solution instead of building the capability within their EHR?
That's right. Yeah, this is a tricky one, and it can be charged in boardrooms because, as you know, as our listeners know, EHRs would seem like the best place to start to build those capabilities, given the investment in time and resources in them. But most health systems that I've spoken with have realized how difficult and time-consuming it is to not only build software, but manage the hardware logistics of device distribution, device pickup, device cleaning, and redistribution. Plus, there's the need for ongoing tech support. And I'm guessing you know as many clinicians as I do who want to care for patients. They don't want to be in the business of managing hardware and software. And so, if there were no alternatives to Epic on the market, then Epic's Care Companion might be more popular, but there are a great many alternatives that can really accelerate and simplify adoption and ultimately scale across an organization.
Okay, so you touched on this a little bit before, but how can remote monitoring improve chronic care management?
Yeah, remote monitoring as a technology is widely popular because it's widely extensible. It's incredibly flexible across a number of conditions. We've seen them being used in a variety of non-clinical settings, from homes to schools, and for a variety of conditions, from asthma to COVID to pneumonia. But in our research, we found most of the action is focused on 4 primary chronic conditions: hypertension, congestive heart failure, chronic obstructive pulmonary disease or COPD, and diabetes, or some combination of those 4 conditions. Really, the leading solutions engage patients with their own data. They also engage patients with pertinent education delivered in a fun and easy to access formats such as videos, as well as nudges to increase self-care. Remember, it's time to take your medication. Remember, it's time to share your blood pressure reading. I believe that the best solutions on the market really can support care teams with risk stratification, with configurable alerts, specifically to avoid alert fatigue, and other clinical guidelines that really just support care delivery and take some of the guesswork out of the hard work of chronic condition management.
Right. So my next question is related to cost. So how can remote monitoring help rein in some of these soaring healthcare costs that we all are very aware of?
Right. And with seemingly no end in sight to that upward trend. I have come to a very firm belief based on the modeling we've done, as well as the real results we've seen, that that remote monitoring has a place in the healthcare ecosystem because it can reduce those avoidable admissions, readmissions, avoidable ED visits, and the like. And really, consumers and payers are demanding this kind of innovation to deliver greater affordability, especially when they increasingly view hospital care as one of the most expensive parts of the healthcare system. So remote monitoring really shifts care from hospital to home and can delay or reduce disease progression and costly treatments. Done well, according to our modeling, remote monitoring can reduce the risk of those avoidable episodes to the tune of $5.2 million for every 500 high-risk Medicare patients with multiple chronic conditions. So these aren't pennies and dimes. These are the big dollars, and the wise health systems are recognizing the opportunity here, and innovative payers are starting to think more seriously about how they really support and power up use of remote monitoring and in their health system partnerships.
Great. That's really interesting, especially what you said. Payers are realizing that. Have you spoken to anybody? I mean, I don't know if you can tell us. It's probably very hush hush, but what are some of maybe the things that you've heard from payers specifically?
Yeah, it's a great follow-on question. Where I've seen the most traction in the media, that's what I can really share is any public-facing news, is where payers, and specifically Medicaid payers, are interested in reining in the costs and improving quality for a specific population. I've seen evidence of, again, the OB population, so pregnant and new parents being monitored, specifically those who are at high risk for preeclampsia, that's hypertension. I've seen evidence of some payers in the Northeast, particularly in the mid-Atlantic states, who are actually funding the software and the device for health systems to then implement, which is a really unique model because at the end of the day, remote monitoring, when it comes to dollars and cents, really benefits the payers. From a health systems perspective, they're most focused on improving clinical outcomes, and they're the most trusted source in healthcare delivery. So it makes so much sense for the payers and the providers to really team up in a partnership that works financially as well as clinically.
Right. Well said. Well said. Okay. So my next question is, what are some of the challenges that health systems face when they want to implement remote monitoring?
Yeah, well, it comes in really three flavors. So the first flavor is choosing the right place to start. And in fact, I'm working with 3 health systems right now at this very moment to identify the best places to power up remote monitoring. And they're thinking about a variety of clinical and business levers. Because I said earlier, remote monitoring is so extensible, so flexible, that choice of where to start can feel overwhelming. But we have tools and methodologies at Avia to really help health systems think through that, including impact models. The second flavor of challenge is really moving too fast. I've worked with some health systems where we've discovered 15, 16 different remote monitoring solutions all across their enterprise because innovative clinicians just want to get stuff done. They really want to test new technologies, test new ways of delivering better care. And so I call that the too fast variety. And, that's not a bad thing, but think the downstream effects is it's very difficult for the CIO, the CMIO, and other service lines to manage multiple platforms at once. It's much better to really come together, build stakeholder alignment, and choose one enterprise platform that works across all service lines if possible. The third flavor and the final flavor of challenge is really moving too slow. We've seen this show up in belaboring the decision about the right vendor. Due to either incomplete inputs at the start of their process or complications or even confusion or conflict around the strategic positioning related to eligibility, operations, and the like. And that's what gets me up every morning, actually, Jeanette, is I love to work with health systems on resolving some of these issues so we can really help accelerate their decision making so that they can get on with the business of caring for patients in a more effective and efficient manner.
Right. So what you said about having so many choices reminded me of just like watching Netflix, right? There's so much stuff you literally can't decide, or at least me. But my next question is, so some of the challenges that you laid out, how can health systems overcome these challenges?
Yeah, well, we take a pretty structured approach, and one that we have tested and refined over many years. So we really offer 3 types of services that can accelerate that decision making. First, we help health systems align their stakeholders by establishing the most strategic starting points and use cases. The second type of service we offer, and these can come in succession, or health systems can enter at one or more of these starting points. The next is we evaluate the moves that will yield the greatest clinical and business impact, and we help health systems choose among those moves. And then finally, we will work with health systems to identify their priority features, functions, requirements, scan the market for the best short list of solutions that are likely to meet their needs, and then we'll actually facilitate the product demonstrations, produce scoring tools, produce our own analysis with stakeholder input, and really help health systems make that decision the best fit for them.
Okay, and right now the solution landscape is super crowded. How do you make sense of that?
Yeah, last time I checked, there were at least 160 solutions on the market that call themselves a remote monitoring solution, which is incredibly overwhelming. We tried to break it down into simple categories. I really view those 160 in the lens of 4 different categories, starting from highly provider-directed to highly consumer-directed. So the most provider-directed solution, which really serves the smallest population, are those acute monitoring solutions. So these are solutions that really generally don't go outside of the hospital, but they are monitoring for movement in the room, falls prevention, and may actually connect one hospital to another, especially where the care team is spread out, and some more high-risk specialized care team members are in one site off from another site. In the middle band, kind of a combination between provider-directed and consumer-directed, we see that the enterprise connected platforms. So these are platforms that come with multiple connected devices. And when I say connected, I mean these are connected by Bluetooth, by cellular points that just upload data seamlessly, and can be pushed into the health system's EHR. These are the most flexible types of solutions for a wide variety of use cases with pre-built care pathways and plans, really easy turnkey type of solution. Another type, or the third type, is really condition-specific solutions. So these are solutions that may not be as easily scaled across an organization, but where they excel is in going really deep on a specific condition. We're seeing several solutions be experts in meeting the needs of pregnant and postpartum patients. Orthopedics is another specialty, as well as pediatrics, including NICU. And so those are, I would say, the top 3 types of condition-specific solutions. And then the fourth category are really non-connected platforms. And I asked yourself, what does non-connected mean? Well, it really means that that the vendor is using the lowest tech possible to extract that data from the patient and send it to the care team. So think about simple SMS texting or interactive voice response, IVR technologies. These are true technologies, but they're incredibly accessible and very scalable. So they tend to be a little bit lower cost because they don't rely on the need for devices. And they can be really highly valuable for care plan adherence and for monitoring larger numbers of people at once.
Okay, great answer. So my next question is, once a health system has decided to implement remote monitoring, who typically monitors incoming patient data and intervenes if necessary?
Yeah, so we've seen health systems take one of two paths. In the first scenario, we've seen what we call a completely centralized model, where all the decisions about who the vendor is, the operational workflows, the device logistics and management, everything is centralized, including the monitoring. You were talking about the monitoring itself. That's a fully centralized model where there's a virtual health team and an innovation team who are working together to not only stand up that solution in the monitoring, but also scale it. The second main type of direction we're seeing is what we call a federated model. So that is where there are some centralized decisions being made, like who the vendor is, what the clinical guidelines are, but then all the monitoring is done in local practices. And that kind of a model can be better for health systems that where the provider practices are a bit more autonomous, and those provider practices really want to do the work of the monitoring. They want to be involved. They want to be accountable, and they're not really willing to give that over to a centralized location. I will say about a year ago, we saw more health systems in that federated model. They weren't ready to move to a centralized model, but honestly, I think through COVID and also the opportunity to build command centers and virtual health centers and teams with the COVID compression, really, we've seen more of a move to a centralized model.
Interesting. That makes total sense. So how do the top companies in this space differentiate from each other? You said there were so many, so.
Yeah. Well, besides those original categories that I mentioned, well, let's just take the enterprise connected platforms as an example. The way they differentiate comes down to questions about the hardware they offer, the software they offer, the services they offer, and more, we're seeing how they approach this notion of delivering health equity. So on the hardware side, some examples could be, do they offer a set of preferred devices, meaning there's not much flexibility to add new devices to the standard kit, or are they device agnostic? Bring your own device, we'll figure out how to connect it. On the software side, some of the differences include kind of what data is shared, with whom, and how. So some solution companies offer, for example, not just bidirectional communication through different modes like video or a patient portal, but they'll also offer the ability to bring in a third party to any video visit. So whether that be another care team member, a specialist, or even caregivers, sons, daughters, spouses of the patient being monitored. On the services side, we see key differentiators in terms of logistics support. Some offer care management services, actual care clinical delivery teams who can do the monitoring. And we see quite a bit of variability in terms of the robustness of the integration into Epic, Cerner, and the like. And then finally, in terms of equity, the big differentiators are you primarily connected to the internet or cellular? Cellular tends to be an easier access point, greater reliability, and then ease of use. How does the platform appear from a consumer's perspective? Is it easy for somebody with functional impairment or cognitive impairment, or is it difficult for those individuals to really understand what's being asked of them and support the monitoring itself?
Very interesting. So there are so many different types of titles and roles and individuals working in hospitals and health systems, right? Mm-hmm. Who are the decision makers that you work with in these systems?
Yeah, I'm just scanning over the last year of projects, the titles of the people I've been working with. They're generally population health leaders, digital health leaders, virtual health leaders. We work with a lot of innovation and strategy leaders. We're also working with a lot of committees. So generally, all of those types of titles working together to make, to align and build consensus and then make decisions together.
Okay. And who are the influencers or stakeholders in selecting a solution company?
Yeah, this is where a project can go off the rails really fast, or it can really accelerate and succeed. It's really important that leaders, the care management leaders are involved, specialists, primary care operations leaders. Incredibly important to include the CIO, of course, that seems like a no-brainer, the CMIO. Increasingly, we're really encouraging health systems to bring the CFO in early and often, or a member of the finance team, to really help them understand the strategic levers that will lead to a strong return on investment. And then finally, we're seeing more interest from emergency department service line leaders, because especially when they're feeling the effect of capacity demands and really needing additional tools to help move some of those patients who show up in the ED to be monitored at home if they really don't need to be admitted to the hospital.
Interesting. Okay. How do hospitals or health systems begin to evaluate solutions in the market? Where to start?
Yeah, a story I've heard time and time again is, and I hear this from the solution companies themselves, is we've been working with Excel system for 12 months. We're almost done with our deal. Or we've been working on this one particular client for 18 months and they still haven't made a decision. This is really where our methodology is important, to really align the right stakeholders to get on the same page around the primary use cases. And most importantly, really just start with the problems you're trying to solve. If you name those problems, those key problems, whether it's problems with inpatient capacity, problems with ED capacity, problems with your value-based contracts, problems with readmissions, certainly it's a matter of just really starting there and then figuring out if and how remote monitoring can solve for those problems. That, of course, always leads to, let's name the top 3 use cases. Once we have the top 3 use cases, then we can start to evaluate the solutions. I think one of the biggest mistakes that health systems make is they jump right into solution evaluation. And they're not really well aligned on the problems that they're trying to solve and the eligible populations that will really help them power up clinical and business levers. So once they kind of align on those strategic imperatives, they can turn to Avia Connect, which is a free resource. Any health system that is part of the American Hospital Association has access to our Avia Connect portal. And Avia Connect is a great place to do your own research and to do it really quickly without having to Google all these different solution companies and do your own research. So Avia Connect allows health systems to understand the market landscape, the scope of the specific topic. And of course, we work on hundreds of topics, not just remote monitoring. You can also learn what good looks like for a topic. And what good looks like in remote monitoring is completely different from what good looks like in, say, community resource referrals or virtual visits or care management or caregiver support. And so you can quickly understand the things that the experts at Avia are really looking for when we evaluate solutions. And then finally, there's a pretty nifty profiler that Avia Connect has developed in the last year or so that allows you to match your profile to a match score of solutions that have been found to be working with those types of health systems. So it's kind of a nifty way to really start to take the 160 and then just funnel it down so that it makes your life a lot easier when it comes to comparing solutions against one another.
Very, very well said. And you make it sound so easy. So before I get into the questions from our audience, my final question for you today is any words of wisdom, or perhaps where do you see remote patient monitoring going in the future? Do you see more health systems, implementing these practices?
Mm-hmm. Yeah, I do. And in fact, actually in the next month, Avia is going to publish our point of view on the key capabilities for delivering care at home at large. And that extends well beyond remote monitoring, but remote monitoring is one of 9 digital capabilities that we think are important for the future. So think about if you and your health system are really interested in expanding beyond inpatient services, and you should be if you're not already. We think that remote monitoring is part of that core foundation, but we acknowledge that there are other digital capabilities that you're going to need to have in the near future or further down the road to really compete, to preserve your market share, and even to grow in the future.
Great. Well said. So like I said, we've already had some questions come in from the audience. However, we would also like to remind you to use the Q&A box to the left of your video window at any time. So let me pull up these questions here, Sarah. We'll get started. So the first question I have for you is, how does remote monitoring fit into the value-based care setting? I am specifically interested in understanding the points of motivation and proven value / return on cost. Value-based systems have limited budgets and are hesitant to spend on RPM because unless in the setting, they don't get reimbursed for the cost directly.
Okay. Yeah, it's a really good question. So whoever asked that, thank you so much. I'm so happy to hear this question as the first question, because I think this is where our country needs to go, is to deliver greater value. You're right, in a fee-for-service environment, there are reimbursement codes available to get some payments, some revenue for the remote monitoring itself. But I want to make sure you understand that most of the reasons that health systems I've been advising are moving to remote monitoring is not necessarily for the reimbursement. It's primarily for the cost savings and the quality improvements and positioning yourself as a strategic partner for value-based payers. And so every time we're called on to run a business case insights project, we generally start with, all right, how can we free up your inpatient beds? How can we deliver on the promise of fewer readmissions? How can we deliver on that promise of better quality and less total cost of care? And then the reimbursement for fee-for-service systems is the icing on the cake. So while you might think that traditional health systems are starting with the revenue question, they're actually starting with the value question, because they recognize that they have work to do in terms of improving transitions of care and really reducing those clinical exacerbations.
Okay, so I can read you thank you. That was very well said, and that was a very good question. So our next question is, when we think about RPM in the context of 1, remote monitoring solutions in the general sense, a service or device that enables remote monitoring, and then 2, the FDA approved RPM devices, perhaps the ones that fall into the highly provider directed bucket Sarah described. Mm-hmm. How do you think this FDA clearance, or lack thereof, influences a payer's willingness to invest in said RPM? And does this clearance designation influence what the budget pool the RPM vendor fits into for the payer?
That's a loaded question. I would say that having FDA approval for the devices is table stakes. In fact, most of the leading solutions that we work with have a library, so to speak, of those FDA approved devices. The question about FDA approved platforms is different. Those FDA approved platforms, the software, are a little bit further, and there aren't as many of those. Those are primarily for those inpatient acute monitoring situations. So I think it's really important for health systems to think about the FDA approval, but it's most important on the device side of the house as opposed to the software side of the house, at least how we're seeing health systems lean into delivering more care at home.
Okay. And unfortunately, that's all the time we have for today. I would like to thank Sarah for today's excellent webinar, and I would also like to thank Avia for making today's program possible. Finally, I want to thank everyone in our audience for joining us. We hope you'll join us in the future for another healthcare innovation webinar. This concludes today's presentation.
Bye.